Hello. Thank you very much to the organizers for the opportunity to speak today on the roles of cardiovascular biomarkers for stratification of cardiovascular risk in oncology patients. These are my disclosures. So what is a biomarker? A biomarker is any characteristic that can be measured objectively and evaluated as an indicator of normal biologic process, pathogenic process, or a pharmacologic response to an intervention. So biomarkers are proposed as a method for improving risk prediction and identifying subclinical disease in patients at high risk for cardiotoxicity from cancer therapy. The definition here is intentionally broad and not limited to circulating biomarkers, but those are the ones that have been primarily studied due to rapid and low-cost measurements. Biomarkers are most useful when accurate, easy to measure, and provide useful information. Biomarker studies in cardio-oncology have been limited due to small sample size, no standardization of time points, heterogeneous assays, which differ in positive and normal thresholds. The accepted cutoffs and reference values have not been established for patients with cancer on anti-cancer therapies, and many of the non-cardiotoxic causes for biomarker elevations are seen in the oncology population, such as sepsis and renal dysfunction. Most of our data is with troponin and BNP, and most of the studies have been done in anthracycline and trastuzumab. The primary outcome studied is a change in LV ejection fraction. Cancer therapy-related cardiac dysfunction will be used throughout today's talk, which is a decrease in ejection fraction by greater than 10% to a value at least less than 53%. We recently received some guidance from the European Society of Cardiology, Cardio-Oncology guideline statement on the use of baseline biomarkers. And this guideline statement advocates for measuring baseline biomarkers such as troponins and BNP in all patients with cancer risk of CTRCD, especially if these biomarkers will be remeasured while on treatment. The release of biomarkers differ based on different cancer treatments and different clinical situations. And this talk, we will focus on three specific cancer treatments: anthracyclines, trastuzumab, and immune checkpoint inhibitors. As you're aware in this audience, anthracyclines can have acute, subacute, and chronic phases of toxicity, which really represent a continuous spectrum of pathophysiology going from the acute reversible to the chronic irreversible, with increasing doses and coexisting cardiac risk factors that determine the rate of progression to cardiac dysfunction. So there are several recognized risk factors, including cumulative dose, method of administration, baseline low EF, older age, pre-existing cardiovascular disease, prior or concomitant mediastinal radiation, and concomitant cardiotoxic chemotherapy such as trastuzumab. Let's quickly review the cardiac troponin complex. So cardiac troponin is the component of the sarcomere, which is the contractile unit of the heart, and it has isoforms C, I, and T. When calcium binds to troponin C, it moves troponin T, thereby exposing the myosin binding sites and allows myosin to bind and lead to contraction. Highly sensitive troponin assays, by definition, must provide measurable concentrations above a limit of detection of greater than or equal to 50% of healthy individuals. Dr. Cardinale and colleagues have done a lot of seminal work in biomarkers. This is one of the earliest studies that was done looking at troponin I almost 20 years ago. They evaluated 204 patients who received high-dose chemotherapy and checked biomarkers 72 hours prior to every chemotherapy cycle. Those patients with a troponin I positive were more likely to have a decrease in LVEF from 1 to 3 months, and which then persisted at 7 to 12 months. Troponin I positivity was more likely to have a decrease in LVEF less than 50% and also to result in heart failure. Of note, this study really has not been able to be replicated due to the higher positive threshold for troponin and the very high doses of chemotherapy that were used. And the frequency and sampling of troponin also is impractical and costly. In a subsequent study, the same group looked at using more of a contemporary assay, which used a threshold of greater than or equal to 0.08 nanograms per milliliter. In 703 patients who received high-dose chemotherapy, troponin was checked before and then early after treatment, which was within about a month after, and these patients were followed for 3 years. They divided patients into 3 groups: those that had troponin that remained negative, those that had a positive troponin that then became negative, and those that had positive troponin that remained positive. What they found was that patients who had a negative troponin at the start and end of treatment, those patients had a very low incidence of cardiac events, about 1% during the 3-year follow-up. However, those patients that had elevated troponins at the beginning and then at the end, these patients were more likely to develop a decrease in LVEF and adverse cardiac events such as heart failure, arrhythmias, and cardiac mortality. Also, importantly, the rise and fall pattern, as opposed to a persistently elevated pattern, may be able to differentiate acute versus chronic myocardial injury, which is also may be useful in the care of cancer patients. Few studies have been done with troponin T with mixed results, and there's also limited data with highly sensitive troponin. In the PRADA study, sub-study that evaluated troponin I and troponin T in patients who received epirubicin with cumulative dose greater than or less than 400 milligrams per meter squared, they found no association between elevated highly sensitive troponin or cardiac troponin T and a change in ejection fraction. Both NP and NT-proBNP have been used for the diagnosis and prediction of heart failure. They are mainly triggered by wall stress from congestion, and the use of NPs for identifying those at risk for anthracycline-induced cardiovascular dysfunction is less clear, but there may be some value in high-risk patients. In this study of 109 patients who received point-of-care biomarkers before and 24 hours post-anthracycline chemotherapy, they found about a 10% cardiac event rate. All patients had elevated BNP, and those patients, and you see the box plots showed both in A, pre and B, post BNP levels, that patients with cardiovascular events, who are the shaded box plots, had elevations in their BNP. So the major consensus recommendations generally support the use of troponin or natriuretic peptides in identifying patients at increased risk for cardiac toxicity from anthracyclines. There are several novel biomarkers that are being evaluated, such as ADMA and MMA, which play a role in endothelial dysfunction and doxorubicin toxicity, as well as looking at microRNA levels. So the ESC guidelines on biomarkers with anthracyclines show here that there's a class 1 indication for obtaining biomarkers in the high and very high risk patients at baseline, and then with every cycle of cancer treatment, 3 months and then 12 months post. And those with low moderate risk, so those are patients who've received greater than or equal to 250 milligrams per meter squared. These patients, there's a class 2A or 2B indication to check biomarkers at every other cycle and then 3 months post. Changing gears to trastuzumab. So the FDA approved trastuzumab in November of 2006, and this was a really a milestone moment in cancer treatment. It targets the HERB-B2 oncogene. It's overexpressed in about 15 to 30 human breast cancers, and it is associated with increased tumor aggressiveness, early disease progression, and high risk for relapse and death. About 10% of patients will develop trastuzumab cardiotoxicity without prior anthracycline exposure, and those who receive sequential treatment with anthracycline, the incidence is about 25% at 12 months. Clinical heart failure is less common, and what we see is largely reversible. There are many new anti-HER2 therapies on the market now. Generally, they have lower incidence of LV dysfunction and heart failure, and there's no increase in cardiotoxicity that is seen with dual versus monotherapy. Also, there's a new study that is showing that metastatic low expression HER2 patients may benefit from anti-HER2 therapies, so we'll be seeing more of this in the future. Risk factors for trastuzumab toxicity include a low baseline or post-anthracycline ejection fraction, structural heart disease, cardiovascular risk factors or comorbidities, concomitant, and sequential use of anthracyclines. In a study of 251 women receiving trastuzumab for early stage HER2-positive breast cancer, 19% of these patients who had an elevated baseline ultrasensitive troponin I developed cardiac dysfunction during trastuzumab therapy. And the cutoff here was 0.8 nanograms per liter. Baseline high troponin I was also found to be a predictor of a lack of response, a lack of recovery despite optimal heart failure therapy. This was again examined in the largest study looking at trastuzumab, troponin and trastuzumab patients in a sub-analysis of the Herceptin adjuvant trial or the HERA trial. In this study, 533 patients with HER2-positive breast cancer received trastuzumab and had serial measurements of troponin I, highly sensitive troponin I, and highly sensitive troponin T. And they found that the increased baseline pre-treatment highly sensitive troponin I and T were associated with a four-fold increased risk of cancer therapy-related cardiac dysfunction. Other studies have looked at multiple biomarkers and newer biomarkers because it is hard to tease out the role of biomarkers with trastuzumab alone, because a lot of these studies have enrolled patients who've received serial therapy with anthracycline followed by trastuzumab. This study looked at several new biomarkers. It was done by Dr. Bonnie Key and colleagues. They looked at GDF15, which is a growth differentiating factor, MPO, which is myeloperoxidase, PIGF, placental growth factor, SLFT1, soluble like tyrosine kinase receptor, and galactin-3. What they found when looking at all of these biomarkers that there was a greatest risk for toxicity when there was an interval change in cardiac troponin I and MPO. And what they were able to show that is that MPO specifically is being studied to identify cardiotoxicity risks because of its role in the innate immune response generating reactive oxidative species, which is thought to be a mechanism for the development of toxicity with anthracycline. So when both ultrasensitive troponin I and MPO are used together, they can provide some additive information. And this probability for toxicity at 15 months when both biomarkers are elevated, it was about 50%. Independent validation is still necessary for this study. In this next study on the graph, you'll see that the trastuzumab line is green, doxorubicin is red, and doxorubicin plus trastuzumab is blue. So this was a prospective study of 323 breast cancer patients who were treated with anthracycline and or trastuzumab and were followed for 3 years. And what they found was that highly sensitive troponin, greater than 14 milligrams per liter at anthracycline completion was associated with a twofold increased risk of CTRCD. Changes in NT-proBNP predicted the risk for CTRCD, particularly in patients that were treated with sequential anthracycline followed by trastuzumab. To summarize, for trastuzumab and biomarkers, baseline cardiac troponin data on trastuzumab may predict a CTRCD and LV recovery. Overall data are generally less robust for the use of biomarkers when monitoring for trastuzumab-related toxicity. Studies have been done usually with serial administration with anthracyclines. Newer anti-HER2 therapies and non-anthracycline-based regimens have less cardiotoxicity, and the utility of biomarkers with these newer regimens does require more study. So in terms of the ESC guidelines on biomarkers with anti-HER2 therapy, there's only one class 1 indication, and that is for checking pre-treatment biomarkers in high and very high risk patients being treated with trastuzumab. Finally, just to touch on immune checkpoint inhibitors as well, this is a new cancer therapy that was approved in 2014. Myocarditis is kind of the most feared cardiac consequence. It can be fatal, but it is rare in less than 1% of patients. There are 3 immune pathways that are exploited by cancer cells, including CTLA-4, PD-1, and PD-L1. The median time of onset for ICI myocarditis is usually soon, so 34 days within a first dose of treatment, and usually presents within the first 3 months. Nearly all patients did have an elevation in troponin, 94%. They also had abnormal EKGs, and about 50% had normal ejection fractions. What the study found was that patients had about a 38% MACE rate despite a normal ejection fraction. So the final or discharge troponin T of greater than or equal to 1.5 nanograms per milliliter was associated with a 4-fold increased risk of MACE. There are some risk factors that are thought to cause ICI myocarditis, including pre-existing cardiovascular disease, pre-existing autoimmune disease, dual immunotherapy, and concurrent immune-related toxic effects, such as myositis. Now, myositis can occur in about 25% of patients. Cardiac troponin T has known cross-reactivity with skeletal muscle, and so cardiac troponin I may be more specific for myocardial injury in these patients. Some other institutions have shown their experience. So Memorial Sloan Kettering has experience with 76 asymptomatic patients with advanced melanoma on combination ICI therapy. Screening with troponin I and EKG found only 17% of patients with elevated troponin I, and none of those patients developed myocarditis. In another study, of 59 patients with non-small cell lung cancer that were treated with nivolumab, only one patient with sustained ICI elevation had subclinical myocarditis. Highly sensitive troponin there still needs to be much more research in this space in ICI myocarditis. And this research letter that was published in JACC Cardio-Oncology looked at 214 patients who were receiving monotherapy or combination ICI therapy, and they found that a positive predictive value of 12.5% for troponin I threshold of greater than 55. In terms of the ESE guidelines for biomarkers in ICI, there's a class 1 indication for baseline cardiotroponin and BNP in low and high risk patients, so anybody starting ICI therapy, and a class 2A indication to check it with every cycle in the first few cycles of treatment, as there are higher rates of ICI within the first month of treatment. So baseline screening with troponin to detect ICI myocarditis. And then for high-risk patients, check troponin with, again, weekly for the first 4 to 6 weeks. This may be helpful due to the time frame that we are seeing the increased incidence of ICI myocarditis. And more data is needed for highly sensitive troponins. This is a nice figure in JACC Cardio-Oncology, which breaks down the biomarkers into sort of 4 biomarker profiles, and the management and the differential consideration. So I urge you to look at that. In summary, pre-treatment NPs and cardiac troponin should be checked at baseline and in patients at risk for CTRCD who will have biomarkers repeated while on cancer treatment to assess for CTRCD. Elevated pre-chemotherapy biomarkers can help risk stratify patients for CTRCD and those treated with anthracycline-based and anti-HER2 regimens. During treatment, elevation of biomarkers, again, troponin and NPs during anthracycline and anti-HER2 regimens can help risk stratify patients for CTRCD, and elevated troponin during ICI therapy may have some potential utility in identifying patients at risk for ICI myocarditis. Post-treatment, a rise and fall pattern versus persistently elevated biomarkers post-anthracycline-based chemotherapy and possibly with immunotherapy can help risk stratify patients for CTRCD. Thank you very much.